Hello, everyone. Thank you for joining for this GDT practical session. So dedicated to the GDT guided dollar class therapy. My name is Mary-Christine Collect. I'm education specialist at EMS Electromedical Systems, a Swiss company which created the Swiss dollar class method at the end of the early 2000 and the GDT at the end of 2020. So I'm responsible for coordinating all the training programs worldwide, and especially online trainings and physical ones. We have the pleasure today to welcome our GDT expert, Dr. Peter Stiller. Peter, thank you for being with us.
Welcome.
Thank you for joining. So Dr. Stiller is a specialist in sports medicine. He's also a specialist in general medicine and emergency medicine. And he's also the former team doctor of the famous football club FC Augsburg 1907. So that was for the introduction. Quick comments about the technical side. As you can see on your screen, you have a chat and Q&A icons. Please feel free to use them to ask your questions, and we'll be answering them during the webinar. So thank you for your participation, and I hope you enjoy this practical session. Peter, you can take the mic.
Okay. Hello, everybody. Sorry, I had to talk to my model. You will see her afterwards for the treatment session. Yeah, I'm very pleased to see that so many participants took place here in this webinar. That's my favorite webinar because this is not only theory, this is more the practical thing, and I love to be practical. You will see it. I don't have to tell something about myself because MC did this. Thank you very much, MC. I want to start with a short summary of the first part, really a short summary just to get something back to your brains that maybe you have not remembering from the last time. And I think this is very important before we start with the whole session. First of all, the GDT, the guided dollar class therapy, is a new kind of therapy plan that we have from EMS. I don't have to explain the first and the fifth and sixth step because anamnesis and rehabilitation and the follow-up is very, I think, pretty normal for everybody who is a therapist and working with patients. But the second, the third, and the fourth step is very important for us because this is as I think, is a game changer to use the dollar class high power laser before you work with your shockwave device. And you know, with both the radial and the focused shockwave device from EMS. And the problem that we had before is that sometimes we think that we need more energy to get better results. And that's exactly what we can do now with the laser. I start with the laser. As I told you last time, we have a therapeutic window between 650 and 1350 nanometers. That's where the laser has an effect on the tissue, and the most important wavelength is the one that the dollar class high power laser has with 905 nanometers, because this is the part where the absorption of water, melanin, and blood is as less as possible, and so it gets very deep and has a very big effect on the tissue. The difference between the high power laser of EMS and all the other lasers is that the peak power is about 300 watts. It's really 300 watts. We did measurements with lasers that are not with 20 watts, what they tell us that they have, but the EMS laser is really with 300 watts, very, very high power, and it is pulsed. That means it goes on and off and on and off. So you have no burning of the tissue, but you have the real effect of 300 watts in the deepest parts of the tissue where you want to have it. The effect of the laser is easily explained. The laser reduces the activity of pain receptors. That what you see here in the right right up here, right upper angle here, is that if you put a pain on the tongue of a cat, like a heat, for example, that makes a pain, the receptors go up very high. And if you do the laser and do the same effect on the tongue again, then you will have much less receptors answering this heat sense. And when you see it, what it does after 10 minutes, it's really a big effect compared to the beginning, or when you didn't have the laser before. And that's what we use, because if there's less pain receptors answering, you have more possibility to put the pressure of the shockwave device higher, and so you have a higher energy density flux, which makes much more effect. The second one is, and that's a nice side effect, I think, it reduces prostaglandin E2. That is important because this is very important for all inflammation in the tissue. And if it reduces prostaglandin E2, it does something that the shockwave doesn't do, because shockwave works with substance P, much more important for inflammation than prostaglandin E2, but we can only use it for substance P, and so we have a combination of prostaglandin E2 and substance P decrease, and that makes the effect much better. Yeah, just as a short summary of what we have technically. The first is the radial shockwave, which has a ballistic generation. It's a projectile that is forced to 90 kilometers per hour by a compressed air. And then if it hits the applicator, then you get here you can see the shockwwaves on the front, and you have first phase of shockwaves, then the secondary shockwaves, and the black ones you see here are the cavitation bubbles that are very important. You'll see it in one of the next files. The same principle with the cavitation bubbles is with the focus shockwave, but the technical part is completely different. Here we have the piezoelectric generation model of the EMS piezoclast with the 1000 piezoceramic crystals generating 1000 little pressure waves, and they come together in one point. The point is called the focus, and you can see the depth of the shock waves, and the middle of the focus is nearly with 4.5 to 5 centimeters, and the gel pad that we use here makes the distance to the tissue, so we can exactly say where we want to work. Okay, sorry. So next one. This is what I told you about the cavitation bubbles, and this is the most important, and I think the one you have to keep in your mind. If you compare what other competitors from EMS bring, only if you see the cavitation, which is for me the same as the energy that goes into the tissue. If you see what they bring with 15 hertz and another one from Storz here, and what the EMS Evo Blue, the handpiece of this is the handpiece of the Doloclast, brings, it is not comparable. This is absolutely it's like comparing a Ferrari to take anything else that is very, very slow. And this is really an absolute this is really a complete difference to all the others. And you see with the EMS device, we have 4 bar, all the others have 5, maybe 6 bar sometimes. And it doesn't matter how much the pressure is. The cavitation and the energy that we get into the tissue is much better if you have the Doloclast than all the other competitors in the market. I can show you this in another picture where the computer counts all the bubbles, and this is even much more impressive because now you see the counted bubbles, and I think this is impressive for everybody. And if you see this, you cannot have another device than the Doloclast. How does it work? It's very easy. You all know the red chili pepper when we are talking about the EMS Doloclast. That's because the principle how it works is the same as capsaicin. This is the what is contained in the red hot chili pepper, and makes the pain and the burning that you feel when you bite on it. And if you do that sometimes, I call it first it burns, then it goes numb. If you do it one time or two, then it burns. After that, it's getting numb. That's the same as you have when you work with the Dollar-Class. You first the pain in the tissue, and then if you keep on that place and you ask the patient, is getting better? Everybody says, oh yeah, now it's getting better. That's because this prolonged activation of the C nerve fibers makes it incapable for some amount of time of releasing substance P, and that's because that's why the pain goes down. And now what happens? The pain goes down. The neurogenic inflammation that is also dependent on substance P is getting down. It's very, very important. The decrease of the neurogenic inflammation plus the release of growth factors and the activation of stem cells makes healing. That's what we want to achieve by using GTD or the Dollar-Class shockwave device. And if you look at the table, what the shockwave device does, it reduces the chronic pain, it blocks the neurogenic inflammation, and the activation of stem cells and growth factors makes together the healing. Also, the blood circulation is improved, and so we have a complete regeneration system, I would say. I always say that regenerative medicine is the future, and shockwave is absolutely, for me, the top of all therapy possibilities that we have to increase the regenerative potential of your body. So this is, these are the two devices again. You will see them in 2 minutes working. This is the high power laser, and this is the new Dollar-Class device for shockwave. And the system behind it is that we want to use the Dollar-Class high power laser for about 3 or 5 minutes with two short programs of 3 or 5 minutes. I'll show you how I use it. And after 5 minutes, or if you have the time, after 1 hour, you will see that the pressure that you can use for your shockwave is much higher. And so the energy density flux is much higher and the results are much better. I will show you. I feel good effect is a little more long lasting, and the healing is getting faster and I think for even longer time. Okay, to show you what I mean, you have this table here. For example, the ankle joint arthrosis. Sorry, it's wrong. I will show you on my model on Claudia because she has the same problem. This was my ankle. I have also an arthrosis in my ankle, and I normally can keep to 2.3 bar, and the pain is much too high. And after the laser, a 5 minutes laser program, I had 2.8 bar after 5 minutes, and after 1 hour, 4.0 bar. That's what I want to show you with her afterwards. And we did this on much more indications. You will see some of them in the case discussions now. And I think this is very important to keep in mind. We can even decrease the effect of the shockwave, the pressure and the effect in the tissue by using the laser. But you can also use, of course, the laser on its own. Sometimes you cannot use a shockwave because it's too painful at the beginning and something, or it is a very severe new inflammation. And if this is coming up, you can use the laser first and put some cryotherapy on it. And after about 12 to 24 hours, then you can start with your shockwave. So we have two possibilities of using the laser. That is very, very interesting for the future, I think. Okay, so we start with the second step. Of course, the first step is the anamnesis. I will tell you the anamnesis while the laser is working on her foot, because her anamnesis is very, very interesting. It is a very special case. She's laughing at the moment, and I will show you. So we just have to change the side. Yeah, just. So. Platz. Can you see that? Yeah, I think it's okay, MC, isn't it?
Yes, yes. Peter, can you stop sharing the screen because we don't see, we see a little window.
Of course, always the same.
Thank you. You look so small in the window. So
wait a second.
Thank you. And thank you, Claudia, for being with us. Welcome. For playing the game.
Is it okay now? Is it gone?
No,
because
it's still I still have your presentation.
Oh, okay, perfect. Yeah, perfect. Okay. Okay. Oh. Okay. Okay. So now we have a 5-minute program that you all have on your devices normally. Sorry. Oh, yes. And the 5-minute program is for an ankle like her. Exactly that what you need for hands, for example. I'll show you afterwards. We take a 3-minute program and maybe 3 spots, for example. There you are very free in your choice. While this is running, I'll show you your anamnesis. Okay, so big applause to Claudia. Thank you, Claudia. Claudia is suffering from a very severe chronic osteomyelitis and osteonecrosis for years. It started with at the age of 11. She had a distortion of the ankle, and afterwards the pain went worse and worse. Then she had to come to the hospital, and then they saw these pictures here with osteonecrosis zones, with bone marrow.
Peter?
Yeah.
We don't see your. I do not see your presentation. Oh, I can see. Yeah.
Do you see it? Because I gave it free.
I see that you started screen sharing, but yeah. I don't see your slide. I cannot see your slide.
No?
No.
Because yeah, my computer says it's given free. Right. Okay, now it's out again, and now we get in again. Wait a second. No?
No, I still have the same message. I don't know why.
Oh, that's funny because my
I'm checking the settings and it should work. Well, it can happen, huh?
Well, I don't understand. It's the same as before. I'm sorry.
I can start. I can try to share my screen as well with the presentation. So, but I don't know.
Because it doesn't matter where I am. It always says the screen is shared.
Yeah. Strange. I don't know why.
Did you see the change? No, I stopped it again. It didn't make a change, did it?
No, still the black screen with the message saying that you started screen sharing, but no slides. Do you want me to try to
Yes, you can
find
try, but I can also get out and come in again.
Okay.
Okay, I try. I go out and come in again. I'm not
Okay.
quite sure why this is happening at the moment.
Okay.
Wait a second.
Sorry, everyone. It can happen. We have just a technical issue. We'll sort it out quickly to get back to this practical session. Thank you for your patience. Ah. Seems to work now.
Can you see it now?
Yes,
So,
seems to work.
okay.
Yes.
So sorry, I don't understand. I did the same things and now it works. It doesn't matter. What I told you before is that she was suffering from the age of 11 from this very severe osteomyelitis. The problem was that she had a distortion of the ankle, and after that the pain got worse and worse, and nobody knew why. And she came into the hospital, and they saw these pictures with osteonecrosis, with bone marrow edema, and everywhere these parts where you see inflammation. And then the next years, she had about nine operations, always with the result that they couldn't get the whole inflammation away. So we had here new bone marrow edema, here new necrosis zones, and as you can see here and over there, the ankle had no real joint movement because it was not smooth, but it was like a like a moon area, like here in this part, because of the bad bone marrow edemas and the necrosis zones. And so she had pain all the time, swelling all the time. This is her left ankle over the years. Here you can see it. Here you see the scar from the operation and the swelling over here. And then we had in 2016, really, again, a very bad MRI, which showed a new bone marrow edemas, which showed a new inflammation in it, and that the osteomyelitis was very fresh again. Terrible for her because the pain was also so bad that she couldn't move properly. Then after 7 weeks of complete rest and immobilization in a plaster, there were some parts that were a little bit better, but some parts getting even worse during this time in the plaster. As you can see here, the bone marrow edema was much more terrible. Here, osteochondrosis zones, no cartilage anymore, and the pain was still there and not getting better. And then the specialists that she went to, 5 specialists of foot surgery in Germany, all told her the only possibility is a stiffening of the upper ankle or amputation. And the last the most famous as a foot specialist, told her to do the amputation because the other one is only time that you lose when you do the arthrodesis, and the amputation will come anyway. And that was the part when we decided to do it another way, but I will show you the rest of the story after all the cases and when we start the treatment with the Doloclast. But keep that in mind, a very bad history and really very, very, very bad time for her. Today you cannot see it, but it was a depression time. Okay, so now we turn around again. Okay, so here we are again. Now I show you some cases just to tell you or to show you what GTD can do, and some indications that I want you to have it seen once, that you can do that with your dollar class, because I think if I can show you something that you haven't seen before, you may try it with your patients, and I'm quite sure you will be successful and do it in the future. So the first part, as I told you before, is we show you what GTD does. In this case, we have a lady with polyarthritis. We work on her hands for about 1 year when this laser came up, and it was always the same story. We started with 0.3 to 0.6 bar at her hands because it was so painful. We couldn't exceed the pressure higher than 1.2 or 1.6 bar on the other hand. It was not possible because it was too painful, and she had to come back after 3 or 4 weeks because then the effect went away and we had to do it again. Then in July 20, when I first had the possibility to use the high power laser, we did the same again. And after a 5-minute break, it was possible to use it with 1.5 to 1.6 bar on the hand. We had 1.2 bar before, and 2.0 bar on the hand. We had 1.6 bar before, after 5 minutes. And after 1 hour break, she came back again 1 hour later. We had on the better hand 2.5 bar, and on the other on 2.4 bar. And I think to come from 1.2 to 2.4 bar, this is really a difference. And the much more important thing was the result, because after 8 weeks, I told her to come back after 4 weeks if the pain comes up again, as we know it from her. But if it's better for the first 4 weeks, she should come after 8 weeks, and she came after 8 weeks, and she had the same result as normally. After 3 weeks, the pain was completely gone for these 8 weeks. And so, wait, this is another one. So our thinking was, if we use the GTD in this case and can have the result of doubling up the time when the patient has to come back, then we can do it with everybody. And I show you 2 more patients. This is a 65-year-old female patient with a very severe polyarthritis. You will see the picture in a second. She was suffering from polyarthritis from the age of 29, the same as her mother. So I think she got it from her mother. And now at the beginning, it was very painful. She couldn't move her hands, and in the morning had to do some exercises to start the day. She couldn't wear her wedding ring, and it was really terrible. You see the fingers here swollen everywhere, and that these fingers are painful, I think everybody can imagine. Then we treated her. As you can see it here, this is all the pictures. So we see the dual clasped behind, and we treated always both hands completely, all the joints and all the soft tissue between it. And when we started, after 4 treatments, we had the patient symptom-free everyday life, and she could go on working again, and she could wear her wedding ring, because the swelling of the fingers decreased so much. And then we could manage that she came every 6 weeks, and that was enough. Then we started after years. You see, it was 2017. After years now, with the possibility of the laser, we started to do the GTD, 3 parts on the hands with 3 minutes, so 9 minutes per hand. And after 1 hour, we had 2.8 bar. You see, we have never been higher than 1.6. And we had 2.8 bar, and that's how we work now. She's coming every 10 to 12 weeks. I mean, this means 4 to 6 times a year, and is completely pain-free with her hands. And you've seen the hands, so this is really impressive, I think. And the last one is nearly the same, and I keep it short. The same bad hands, I would say. The possibility to get higher than 1.5 bar was never there. The patient was very, very happy with this 1.5 bar because it meant 4 weeks, maybe 6 weeks of pain-free. Now we have 2.6 bar with the GTT, and we are also with 10 to 12 weeks. Completely different indication is the patient with cervical and lumbar spine syndrome. That has a lot of diagnosis as well in his cervical and his lumbar spine. I show you the MRI reports. The blue parts are that you see easily what he is suffering from. So the spinal canal stenosis, constriction of neuroforamina, and osteochondrosis, of course, very, very bad spondyloarthrosis. So it means that he has a facet syndrome that is very, very painful as well here as the lower back. And he was in a very famous clinic here in Augsburg, where I'm living, only for private patients, very high settle, I would say. And they told him, no chance with any conservative therapy, you have to be operated here and here. I have to tell you that this patient is 59 years old, but very, very athletic, very strong. He's doing thousands of kilometers on his bicycle every year, and working in a gymnasium and so on. He's really strength training. He's really doing a lot, and he couldn't do anything at this time. You see it here. He was not able to stand up or move his head right, because it was always like a stiff neck. It was really, really bad. Show you the second part. This is for the cervical spine. Here you see the same narrowing of the neuroforaminal spinal canal stenosis, extensively activated erosive osteochondrosis. So this is really, really painful. As you can see it here, it was the visual analog scale was between 7 and 9 when he was not doing anything. When he tried to do sports, it was not possible. And here is what the clinic said. Midterm spinal fusion. That was funny, because midterm meant that he went out of the clinic and he had the appointment in his hand for next week for the operation. So then he came to me and said, when I'm getting operated and they want to stiff my vertebrae in the lumbar area and in the cervical area, can I do any sport in the future? And I said, oh, this is nothing that you can expect, because do you see me? The video was stopped. Okay, sorry. And then I said, okay, I have another possibility for you. We try shockwave therapy. And if it's not getting better the next 4 to 6 weeks, we can rethink the plan of an operation. I'm sorry, but I think my internet is not so good. Do you see me, MC?
Yes, I totally see you on the screen. There are some cuts, but it's fine. The network is fine.
No stopping of the video, because in my screen it always stops. Okay, sorry. That's how we treated him. Just to see where we work. I can show it on Claudia afterwards, how we do this, because this is really important. You cannot do any harm to the vertebrae, to the facets, to the facet joints. Nothing can happen if you keep to the spine. And we worked on him 4 times in 4 weeks. And after this 3 or 4 treatments, he was pain-free or nearly symptom-free. The visual analog scale was, you remember, 7 to 9 normally, was 1 of 10. So from 7 to 9 to 1 in 3 or 4 treatments. And he could do his sport again. And we are now working on him every 4 to 6 weeks. And he's doing everything. He did an Alps, how do you say, when you ride with your bicycle over the Alps. That was what he did 2 weeks ago. I think 3,000 kilometers without any problem. Afterwards, he came and said, oh, now I have a visual analog scale of 2, and now we have to work on it. So this without operation, you really have to try it with your patients. If you work on the back, you can have great results in movement and pain-freeness. It's really great. Here is a video. It's in German, so I don't show you now. What I want to show you is that he was so pleased with this result, and he found it, the result so great that he sent me a video. It was the first selfie, the first video of his life. So that shows how important it was to him and how happy he was that he was not operated and could do his sport again. I'll show you a few seconds.
Ja, hallo, Dr. Stille. Wie gewünscht, ein kleines Video von mir. Wir haben uns ja das erste Mal jetzt bezüglich meiner Rückenbeschwerden, so vor circa...
Okay. Just to show you how happy he was when he was doing the video.
Ja, hallo, Dr. Stille.
Okay. Another, for me, very important indication is the frozen shoulder, because we see it more and more. I think maybe that the years before, the people didn't think about the frozen shoulder. It was an inflammation in the shoulder and that's it. But now we have this term frozen shoulder, and I think it describes it very, very well, because the people have pain, but they are frozen. They cannot use their arm. The shoulder is sometimes not movable more than this. And this is how the stages are normally in the books. I don't like these stages because they are so fluent. We don't have the stage 1 and then stage 2 and then stage 3. We have all stages fluently going over to the next stage. But the very important thing about it is that you have a completely restricted movement in the shoulder and very, very painful month, maybe it's the 27 to 33 months on average. Maybe it's a time of 4 years if you don't do anything. Physiotherapy doesn't make the pain better, makes the movement sometimes a little bit better. And then you go out with 3 years and not 4 years. But there is no treatment before shockwave, I think, that makes it really better in short time. Especially not cortisone injections. They all do that, but I had no patient, not one patient that was better from these cortisone injections. Here we have one example. It was a mother of 2 children. She was head of a children's home. So she was really working hard every day. In the early May, she had an overuse of the shoulder because she was using big stones in her garden. After lifting these stones, she couldn't move her arm properly, and it went on over weeks and didn't get better. And then she had these cortisone injections. She had oral cortisone for weeks. After her weight increased more than 10 kilograms, she said, "No, stop, I don't want the cortisone anymore." But there was no improvement of the pain and no improvement of the movement with this cortisone, so she stopped it. She had 5 different painkillers and physiotherapy, and it didn't work at all. The MRI from August 2017 showed the capsulitis, and then she came to me in October 2017, and she had an abduction of 10 to 15%, which means this: you cannot use nothing on the here. You cannot put your clothes on your own. You have to have somebody who helps you. It was really a very bad time. And then she came to me and we started radial shockwave with 1.5 bar at the beginning because it was so painful. And then when after 5 laser treatments and cryolite, that means it's a hyperbaric CO2 cooling therapy, very I think it's very, very good for pain in this stage. And when we used both, we used at this time another laser because there was not the high power laser, but the high power laser would have been really great. Now I only use the high power laser with shockwave for the frozen shoulders because you can start much higher with much higher pressure with much less pain, and that's really great. At this time I didn't have it, but the cryolite and the shockwave brought us to a very good result. After 5 treatments, we had 2.5 bar, and she was able to sleep without any pain in the night, which is very typical for frozen shoulders, that they cannot sleep because the pain in the night is so strong. After 8 treatments, she had an abduction of 120 degrees. this, from 10 degrees to 120 in 8 treatments, which means 8 weeks in this example, and we could use 3.0 bar without any problem in the shoulder. If you can do this, normally the shoulder is, the treatment is at its end. And that's what we did. In 2020, we started to use GTD for it, 2 5-minute programs from ventral and from dorsal. And then we can double up the pressure normally, and it gets better even faster, and it's more long lasting. Okay. This is again a video because she was so happy that she sent me the video just to show you how happy people are, and you treat them with indications that nobody knows that you can treat it. Another part is the wound part, how to use tissue injuries. This is at the age of 41, he fell from a ladder. He didn't break anything. It was a ladder of 2 meters, but there was a piece of metal standing out of the ladder, and this cut his whole leg. You see it here. This is his thigh, and he had a lot of. Yeah, he was very happy in this accident, because if it goes about half a centimeter deeper, I think this artery here will not have hold. And after that, he was. There was an operation, of course, in the hospital here in Augsburg. He had a good surgeon, really. I know him for years, but it developed like this, and that was not what everybody wanted. It got more and more painful, and after a few days, it looked like this. Of course, this is a very, very bad result and very severe diagnosis. And what they told him, what they can do now is debride the wound, of course, leave it open, rinse it, and wait and keep him into the hospital. And then after that, make a muscle flap transposition and skin graft. And this needs 3, 4, or 5 operations maybe, and it lasts 6 to 12 months that it will heal. And they couldn't tell him if he can do any his sport anymore. He's playing football, he's running marathon, and very, very sporty guy, and sport is his life. So he came to me really crying. A 41-year-old man came crying and told him, Peter, what can I do? And I told him, okay, the alternative is to use shockwave to regenerate the tissue. Of course, he got a double antibiotics, a double therapy, of course, and we had the possibility to send him to the hospital to be operated at once when we say, okay, this is not, we cannot do it anymore, we cannot manage it. So the background was very good for us, and then we started, and 8 weeks and 10 treatments later, and I had to put the necrosis zones away 2 times. I've been a surgeon for 4.5 years, so this is something I can really do. And I show you on a video. This is in German. It doesn't matter. The important thing is look at the scar and look at the tissue around it. That's what I say in the video. The tissue is completely soft. The muscle has no problem. And after this is after 8 weeks. He was starting to run after 7 weeks. So this is 1 week of running, 3 times of running, 8 kilometers without any problem.
Schwere Rissverletzung Ende September diesen Jahres, großflächige Muskelverletzung.
I will make it a little bit more short. Now you see the tissue. And now I show you how I work on the tissue, and you see how strong, how much pressure I can do in.
Peter, how many how many impulses did you use to get back to this exceptional result, to get back to this muscle structure? I mean, it's great.
Yeah, you need more than you normally think. Everybody thinks, okay, this area is about 1,500 or 2,000 impulses. No, you need more, 5, 6, 7,000. That's really important.
Per session. Okay.
Yeah, per session, because you really have to work on the edges of the scar on the wound, and you have to go through the wound at the third or fourth treatment when you see now it's coming up, and you have to use it in the whole tissue surrounding it. That's very, very important, because you have to regenerate the whole tissue, the muscle and the soft tissue between it, and the fat between, and so you have to work on the whole area, not only
the different structures of the tissue to get back.
But that's the perfect thing with the EMS shockwave. You can use it for every tissue by going over all of them. That's really great. So you reach every tissue in such examples, and you can have great results, and it's not so difficult, I think. The next one is I think one of the most impressive ones, because lymphedema is a very big theme for me here in my business. I have a lot of people suffering from lymphedema, maybe after breast cancer, for example, or in this case, chondrosarcoma, which had this guy had in his knee and his lower stomach. What I want to show you here is just to have the numbers. Sorry. My mouse doesn't want to work. No, here. It's the size circumference was 74 centimeters. Suprapatellar means 3 centimeters over the patella. You have 74 centimeters. I show you the picture. You cannot believe it. And what they told him is to have an amputation of his thigh. And he said, the patient said, "Yeah, what are you doing with the tumor in my stomach?" They said, "We cannot operate you there." And then he said, "Okay, then I keep my leg." That was a very good decision. And what I also have to tell you about the anamnesis, he had lymphatic drainage 4 times a week, 90 minutes. 90 minutes of lymphatic drainage 4 times a week, and it didn't work at all. Now you see this leg compared to the other leg. I think this is much more impressive as you see only one leg, but here compared to his left leg, it's nearly unbelievable. He had radiation. You see the results of the radiation here at the back of his knee, and here again, and we had wounds there too because of this what the radiation did to the skin. And then we started, we had big fibrosis and induration areas there, of course. Then we started shockwave really from the ankle up to the end of the thigh. Even I was working even in the part where you have the most lymph nodes at the beginning of his stomach. And after you see the swelling was 56 centimeters at his calf, unbelievable. And he had constant pain. The movement was restricted. Of course, he couldn't bend the knee. 20 degrees of maximum knee flexion is not much. And psychologically was in deep depression, of course. Then when we started after 3 treatments, it was really getting a little bit better. So we could work with more pressure on his Achilles tendon. Then the physiotherapists after 5 treatments told him that they want to know what he's doing at home, or what kind of treatment he becomes at the moment. He gets at the moment, because they had much easier the lymphatic drainage got much easier at the first time that they were treating him before, and he was. He had the possibility to sleep more than 2 hours, because the month and years before, he always had to get up after 2 hours, walk a little bit, and do a new compression bandage, and then he could go back to his bed. And now he had 6 hours of sleep, which was a new life for him after 5 treatments. Sorry. Then after 15 treatments, it was possible for him to stand on his toes and to bend his knee nearly to 90 degrees. And after 1 year, I think, yeah, after 1 year, we had a very a great call, because he called me and said, okay, now I was I was working where he's working where you have to present, he's an architect where you have to present your architecture, and he's standing for 5 or 6 hours. And after this time, the leg was swollen again, of course. Then he went on a 30-minute walk, and after the walk, he could see how it went away. So it means that the lymphatic drainage was activated only by walking. That was something that we never expected to happen in the future, but it was possible. And now I'll show you the picture. Now we are years ago. This is a picture after 1.5 years, I think, with 47 centimeters. We are now with 44 to 45 centimeters. He can bend his knee, as you see, more than 90 degrees. He can put on his shoes. He's walking more than 1 hour every day without any problem, and he's no pain anymore in this leg. And this is something that is really possible. Okay, this is work and it needs some time, but if you see 1 year or more than 1 year of lymphatic drainage 4 times a week, 90 minutes without any result, and this is after 1 year, shockwave, I think it is 30 centimeters less circumference of the thigh. Another example for using GDT, an acute ATFL rupture in a German football player is the first league, the first Bundesliga in Germany, the highest class that you can have. And he had an ankle distortion during a game, and the ultrasound that we did 5 minutes later showed a complete ATFL rupture and a massive joint swelling. Then we treated him with the high power laser and cooling therapy, as I told you before, put it into a cooling plaster. And after 12 hours, we did the high power laser again, and we could start shockwave because the swelling went away, the pain went away. And after the laser, we could really work with 1.5 bar on his ankle, which is, I think, with such a fresh injury, very, very good. And after 24 hours, it means 12 hours after the second laser and the first shockwave, he was walking with full load and without any pain. The swelling was nearly completely gone. And we had an MRI exactly 12 hours later, after 36 hours, and they said complete ATFL rupture, only a very slight swelling of the joint. So in 36 hours, we all, even in the MRI, the swelling went away by using the laser, the cooling therapy, and shockwave. And when you do it, or when you go on like this in a professional football player, you get them back on the field in 19 days. And I think we could, for example, we could start the stability exercises on day 2 or day 3, because they are so pain-free and the swelling is gone. And so you get them very, very fast back on the field. In 19 days, I think this is very, very good. 2.5 weeks to get back is very, very good. This is a very, very new case that I put in, because this is a ice hockey goalkeeper in Germany, the second highest league. And he had first he had a partial rupture of his left medial collateral ligament. Then he had a complete rupture of this ligament, which means it's the most important ligament for an ice hockey goalkeeper. I have to show you, because it's here and they always are doing this movement. So they have to do it because they have to close their legs on the ground, that the puck cannot get into the goal. So this is a movement that brings very much stress on this ligament. And normally they say, if you have such a rupture as an ice hockey goalkeeper, this is the end of the career. So we treated him with GTD high power laser and shockwave. After the high power laser, we could put 2 bar on this ruptured ligament. It was really great, because before this we couldn't start with 1 bar. It was too painful. And then he had a treatment every 3 to 5 days. And we could start the stability training 20 days later. 5 treatments later. I think this is really impressive, because then he started to do his special ice hockey goalkeeper training, and was without any problem. In June, he reached the entire training load that he normally had with no issues. Then he had a muscle fiber rupture in September, and we did, of course, shockwave again on the muscle fiber rupture, and we could manage that he started the season the 24th of September, 15 days after the muscle fiber rupture, without any problems with his muscle and without any problems until now with his ligament. And he had 13 games in 6 weeks now. So I think this is really impressive, because this such a stressed ligament in such a sport, to get it healed so good is really, really impressive, and makes me proud for the future, because I'm going to have more ice hockey players. So if this is possible, I think nearly everything is possible. Okay, this is another very young and very good professional sportsman. He's 15 years old, one of the best track and field athletes in Bavaria and southern Germany in his age. He had a muscle fiber tear of the tensor fasciae latae and shin splints on both sides for about nearly 2 years. The muscle fiber tear was, of course, very acute. The shin splints he had for 2 years, and he had to stop some competitions over the last 2 years because of the shin splints, and now he had to stop for him very important competition. It was the Southern German competition with all the best in his age. He had to stop because of this muscle fiber tear. Then we treated him 3 times with laser and shockwave. We also tried to use the shockwave first, and we had the 0.4 bar at his shin splints, and after the laser we could put 0.9 bar on it. And after 3 treatments, we had 1.5 bar on both sides of the shin splints, and the pain was gone. And the pain of his pelvis, where the muscle fiber tear took place, was gone after 2 treatments, and we had 2.5 bar on this muscle. And after the 3 treatments, he could go back to the full training load that he had before. And this was the next competition a few days later. The U16 means under 16 Bavarian Championships. He's under 15, so this was the level of ones higher, and he won two of 3 competitions and was second in another competition, so that he was also written in the newspaper here in Germany. And that was exactly a few days after the last treatment that we had. So and he had no problem with his shin splints for the last, now this is 4 months now. He had no shin splint problems at all for the whole 4 months, and he was suffering for 2 years before. This is another professional sportsman, a tennis player, very good tennis player. It was at the age of 18, he had a severe inflammation of his pubic bone. They told him to rest because he had to quit the tournament of Wimbledon, where he was, the junior Wimbledon, and the US Open were cancelled for him because of this bone marrow edema and his bad pain that he had. Then he had 7 weeks off because the doctor that treated him at this, that's the German, that's like where the best German young players come together. They're working in one area in one tennis gymnasium here in Germany, and they have one very good doctor for such things. And he told him, okay, 7 weeks off, 6 to 7 weeks off, and then we'll see. After 7 weeks, we had the same problem. The pain increased in these 7 weeks, and the MRI didn't get better because this was after 7 weeks of rest. And then they came to me and I said, okay, let's start with shockwave. I have to tell the story that the other doctor told his parents that if you use shockwave on the bone of this professional player, he will break his bone and he will never play professional tennis anymore. That was what the other doctor said, just to show you how much nonsense is told to patients if they don't know what shockwave can do. Then we worked on his pubic bone with shockwave every second or third day and physiotherapy, of course. Laser cryolite means this hyperbaric cooling so that the pain goes away faster. And after 8 weeks, we had an MRI. After 7 weeks, this is after 7 weeks, the 21st of September, after 7 weeks, we had 90 minutes of tennis training without any pain and 3.6 bar on the pubic bone. This is really high pressure. And if this is possible pain-free, you can tell the patient that the treatment is normally over. After 8 weeks, we had a comparison. You see on the left side, the very, very severe bone marrow edema. On the right side here, it is getting better and better. Here you see the secondary cleft sign in the new MRI, which is in this case very, very good because the inflammation went away so good that we can see the secondary cleft. Now after, we didn't do any more MRI because he was completely pain-free the whole time. 1 week, 2 weeks later, here it is, he earned his first world ranking points at the ATP Challenger Tour of the grown-ups, not the juniors, but the adults. And he had no pain anymore until today. That's 2 years ago, or 3 years ago. And today, we always start with the laser because the laser keeps away this terrible pain that they have at the beginning of the treatment with a 5-minute program for or makes it possible to double up the pressure after 1 hour. And that's much better at the beginning because the pain is getting better after 2 or 3 treatments of GTD. Before that, we had to do 4, 5, maybe 6 treatments, only shockwave to get the pain away for the patient. Okay, now we are at the end of the cases. Now I'm turning around and try to get my picture again without any problems, I hope. We do the third and the fourth step of GTD now, means we do the radial shockwave and maybe if we have time, the focused shockwave too on Claudia's ankle. She's sorry, but I think she's afraid of the focused one. We didn't do the focused with GTD before. That's a new one. Afraid. Yeah, she's afraid. Okay, we'll see. And then I show you now, because this is easier, what was the result of the treatment of Claudia. Then we start the treatment. We did one last try with her after 9 surgeries. Was the 10th operation that she had in Munich in a clinic, where we wanted to get all the scar tissue out of this ankle to have a better movement. And the rest of the ankle, I said I will work with shockwave on it. And after the surgery, we started at day 4 of the surgery. That was the day when she came out of the hospital. After 2 weeks, we had nearly no swelling anymore. That was much faster than all the 9 operations before. We had significantly less pain than in all surgeries before. And the mobility improved every week very fast, which was not possible in one of the other operations before. And after 4 months, we had this. Now I show you first the older ones. So remember, these were the pictures. These were the last pictures before the operation and the shockwave. And now you see the pictures after a few months of treatment with the Doloclast. Nearly every necrosis is gone. You see no bone marrow edema, nothing at all. And she was completely pain-free then. Now we work on her ankle about every 6 to 8 weeks, maybe 10 weeks. And it's still a very good result, such a good result that she could fulfill a dream in 2018. She's a big fan of Iceland, and she could visit Iceland in 2018 without any pain. And as you see, this is after a 5-kilometer walk over stones and ice, and there's no swelling of his foot. And because of a tradition, I would say, she sent me photos from her second trip to Iceland 3 years later, this August. And there were much longer trails than 5 kilometers. And every day I got a photo of her ankle, and it was really, really a great result. And now we show you how we work on her ankle. And after that, I hope you have a lot of questions. Okay, so. Yeah, just a mic. You see me?
Thanks, Peter, for the presentation. That was great. Yes, I see you.
Perfect. Nein, alles gut. Okay. I have to tell we are not wearing masks because we are vaccinated and tested. So, and I think you can hear me better. So normally the highest pressure that we reach in her ankle is 2.0 bar, not more. It's much too painful. And now let's see, after nearly an hour, maybe 45 minutes, how high we can put the pressure. Okay, now we are at 3 bar. Oh, this is 3.6 bar. You can see her face, she's still alive. This is 3.6 bar. We normally reach never more than 2.3, normally 2.0, then I stop because it's too painful. Now after 45 minutes after the laser, it's 3.6 bar. And you can imagine that it is much more power that you get into the tissue and into the bone and into everything you want to reach. And that the result must be much better, because higher the energy, the better the result and the effect on the tissue. And in this case, we normally use it everywhere. We recognize that even if we use it from another point, we can go higher. So it means that the laser goes through the whole ankle and not only exactly where you use it. I show you. So if we want to reach the talus bone and her complete ankle from the back, normally you would say, okay, we did the laser at the ventral part of the ankle, and now we use the shockwave from behind. So maybe that we cannot increase the pressure the same way that we did on the ventral side. But we have 3.7 bar, so it's even the same as on the ventral side. That's very important, because if you use the laser and you have to put the laser here and here and here and here and here, they are sitting for an hour only treating with the laser. But if you use it 5 minutes here and you reach the whole ankle, it's great, because the patients come, get 5 minutes of laser, go away for an hour, come back, and you can treat them with doubled up pressure and doubled up energy. And that's what we wanted to show, because this is really very, very impressive. And I think, I use the word again, it's a game changer completely in the market. And you cannot use another laser. That's what I want to say too. I had another laser before EMS started this laser with this 20 or 30 watts. We didn't have any of these results with this other laser. I had it for 2 or 3 years. I used it everywhere. I tried it everywhere, and it was not possible to have any result that is even a little bit comparable to what we have now. That's very, very important. Okay.
Thank you, Peter. We have a question from one of the participants asking, how do you count ESWT in each treatment? Is it based on time, on the duration, or based on the number of shots that you're giving according to the indication?
Normally, it's only based on what feeling I have when I treat. I want to reach a result. I want to see the patient getting better from the pain. Sometimes I use it when I'm moving the joint. I want to work as long on a joint that I can see, okay, now the movement gets better. Because, for example, at a frozen shoulder, I show it here. If they can, sorry. For example, if they can abduct the shoulder like this, you can go under the shoulder. Under the
immobilize the shoulder
higher. Okay, then it's restricted normally when you're talking about a frozen shoulder, and then you use shockwave and put this as high as possible and work on the capsula and work on the tendons.
On the different tendons.
Yeah, on all parts, and then you can see without pullover, of course, and then you can see how the movement gets better and better. And I think it is not possible to tell everybody, okay, use this amount of impulses, or you have to ask if it goes down visual analog scale from 6 to 4, then it's over. Ask the patient how the pain reacts. If it gets better, because it has to get better, then you can turn the pressure higher to see, okay, now the pain is increasing a little bit. Does it get better again? For 2 or 3 times. And if you have a problem with the movement, ask the patient, how is the movement? Is it getting a little bit more fluent? And then I think this is what is important, because then the patient also recognizes, okay, the treatment works, and not telling them, okay, now we do 2,000 impulses, that's it. Okay.
Okay, so it's a customized treatment for each patient.
Absolutely.
And depends on the, let's say, on the tolerance that the patient can.
Yeah, exactly.
Can have towards the pain.
Yeah.
And it also depends on the diagnosis, on the ultrasound.
Of course, absolutely.
Is it a chronic? Is it since a few months or since 2 weeks? Okay.
For example, if you use it for the lymphedema that we saw, this is 20,000 to 30,000 impulses at the beginning. When it's getting better over the month, then you get it with less. But at the beginning, it's 20 to 30,000 impulses. It's not, you cannot do it with less. And for example, a tennis elbow, I have tennis elbows that have muscle problems down here and up to the shoulder, then you need 7,000 or 8,000 impulses. But we have also tennis elbow really only having it in a local area, and you put 2,000 impulses, and the patient says, okay, now the pain is great. And then you can stop, of course. So it really depends on the patient. And I don't like these, this is the diagnosis, you have to do this, and you use it with this frequency for this kind amount of impulses. Because, for example, we all in our network, we are all working with 20 to 25 hertz always, because with this device, it is absolutely not important if you how many frequency you have, because you always have the same power coming out. This is completely different to all the other competitors in the market. So we can work with 20 or 25 without losing any energy. The others can't. So why do we want to work slowly? That's not logical. We work as fast but as good as we can.
Okay, thank you. So you treat differently for each patient. It's customized all the time. Okay.
Yeah.
Thank you very much.
First,
Thank you, Coco, for your question. Interesting question,
very good
by the
question.
way. Yeah.
Does anybody want to see something how we treat or how the combination of the laser and the shockwave works that we saw now? But do you want to see how something that how can you use it for this the shockwave, or how do you put the laser on with this indication?
For
Now
the moment, we have no questions so far, no other question, but yeah, could be good to see an indication that you use for, that you combine with the laser and the shockwave.
I show you
maybe shoulder or a standard indication, or
yeah, I show you Claudia is also suffering from biceps tendinitis.
good example.
Yeah, good example, because it comes from the obstetric. She had a ganglion there that we had to be operated really because it was very big. And after that, now she has a little problem with the scar and with the biceps tendon because the tendinitis didn't go away. And now we're working on this. It's getting very fast, better, very fast. But I can show where we put the laser normally. I will not run the whole program of the laser, but I can show where we use the laser and how we work with shockwave. Okay?
Interesting case. Thank you.
Es ist zusätzlich so, dass du ein bisschen, also dass du da reinguckst. Okay. Das ist am besten.
Weil jetzt machen wir nichts mehr.
Ja, genau, das machen wir. Okay.
Das ist immer noch gut, dass ich das
What we have to show, that's very important. When you use the laser and the patient has a tattoo, the problem is that some colors are getting really hot. And you have to ask the patient if it's getting hot. I try to get away from all tattoos because I cannot ask him every 20 seconds, is it getting hot? Because then you really can burn the skin. In this case, it's perfect because here the tattoo ends and I have to go there.
The fact that it's getting hot and can burn this, well, can burn the skin, no, but is it due to the presence of metals?
I think
supposedly metals in particles of
metal or the coloring in the tattoo.
In the products. Yeah.
Okay. I think that's the problem. Yeah. Because this reflects it maybe and makes it warm there.
Okay, thank you.
Okay. In this case, it's the same. We put it on the point where you want to have it, and do it for 5 minutes. That's enough because it goes through the whole shoulder, and I want to reach the biceps tendon. So we normally use the 5-minute program. I can show some things more, I think. Wait a second. Is it possible to see the display, MC? No, not really.
Yes, but yeah, it could be more precise, but
I just want to show that this is
fine. It's fine.
This is the display where you see the frequency, the modulation, how long is it on or off, the energy that comes into it, how long it goes. Here you see how long it lasts more and how many energies in it. Now I stop it now because this is too long, and go back. What I want to show is that we have 3 parts. We have the indications. You see that? Yeah. We have indications. You can put your finger on every indication, and then you see here diagnosis means indications for the laser. This is already programmed, and you see, that's what I wanted to show. You see, they show you where you have to put it. I think everybody knows that, but you have it in the picture here. And then it's automatically, for example, a program for epicondylitis, very severe epicondylitis with inflammation that is so painful that I cannot start the shockwave. Then I use this program about 15 to 25 minutes. Okay, for example. And the same we have with how it works. So what do you want to do? Trigger points or a patient with a bad pain, muscle relaxants, for example, anti-inflammatory effect. This is very important, the anti-inflammatory, because this is with the highest energy that we have. This is a 90-minute program for bad inflammation. We use the first 5 minutes of this because it's the highest energy for our GDT.
Mhm. Okay.
And this is
When
individual.
you say bad inflammation, is it a big edema, for example?
Big edema, very acute, where it cannot work with shockwave.
Okay.
Yeah. And this is the third one, very important. The individual part means 3 minutes or 5 minutes. That's what we programmed for us. You in the new devices, I think this is already programmed, and you can put your own individual programs too. If you are, if you think, okay, I think 7 minutes is better, maybe, then you can do an individual thing for you with 7 minutes, and you can even use another frequency or modulation and so on. So you have the possibility to be your own king. Okay. That's just I wanted to show how this works and that we have a lot of possibilities. This is really
Customize the treatment.
very well planned from the guys from EMS. Thank you very much for this. Great stuff.
For using the device and showing us your expertise.
Now, what I wanted to show with the shoulder is you can only, for example, we had the problem with the how much do you need. If you only work like this and say, okay, that's the biceps tendon, then you can put it like this, 2000 impulses. I can talk to you during this, but this is not the way I work on the patient. I normally really try to work on every part that can be painful. Sorry. Means I start with the most important part for the patient, the biceps tendon, but of course I go down here. I look at the other rotator cuff tendons, very important, I think, because in most of the cases, the supraspinatus tendon is also a problem when you have a biceps problem. A lot of patients with a biceps problem have a bad body holding. They're always like this. And I think if you work here, you can get this much better. And they have a lot of pain here normally. So you can go up to the cervical spine. This is also very important. Most of the colleagues say that they are not, or that they are afraid to work on the cervical reach.
This area.
Absolutely no problem. I always work with 1 to 1.3 bar. You don't have to have so much pressure there. A low pressure is enough, and you work on the muscles. You work on the facet joints. And that is really great. You can work with patients suffering from migraine, there's tension headaches, even people with a CMD problem. That's really a great area where you can work and you have great results.
Thank you. Yeah.
I work on the shoulder for about a minute just to show, and then we can do another thing if you want. And we talked a lot now. That's something that I want to give to you all. It's very, very important to talk to your patient. It's very good for the binding. I think that the compliance is getting better and better if they know that they have to work with you and they have to tell you, okay, now it's getting better or it's getting worse. And if it's getting better, you have to tell them that you put up the pressure, and then they have to say, okay, there's more pain, now it's getting better. And the talk is very, very important when you're treating with shockwave. If you don't do this, I think it's half of the success is to talk to your patient and to be very,
smart. Very smart to respect the tolerance.
Not because of a placebo, but you cannot work properly if you have not the response of the patient. If you have a good response, you can work better, and that's very important because you have a great device. You have an unbelievable treatment possibility. I think with really great possibilities, but you have to talk to the patient, and you always have to be a team.
Yeah, definitely. So you covered the whole rotator cuff.
No, this was only a short now.
Only a short. Okay.
From here, I can have the infra and the supraspinatus and the biceps tendon. And I would go over here, of course, and also here to get the supraspinatus, the subscapularis too.
The subscapularis, yeah.
So you can work everywhere here. It's no problem. You can also work here on the trapezius muscle and the sternocleidomastoideus muscle. You can even go up to here because you have a lot of patients that cannot move their head properly, and they always have a problem with the trapezius and with the sternocleido. So you can work on both.
Okay, perfect. And you use the flat applicator. Is it possible to use the 15 millimeter, or because it covers more, the flat applicator covers more?
I think that 2 centimeters is also possible, especially when you exactly know where the problem is. But normally I use the big one because I can get everywhere and have bigger areas of the muscle that I can treat with. But if you have the problem, for example, at the supraspinatus, you can use the 2 centimeters. You can even use one of the others, the 15 centimeters, or another possibility, the little bit curved, the little bit curved 15 millimeter. That's they try to do a little bit like a focused, because it's getting on a
getting more, yeah.
That's really the case. It's a little bit more painful, and if you have the point exactly, then I think you can work with this very good. But in most of the cases, I use the big one, really.
Okay, thank you.
Especially with the hands, because if you use the smaller one for the hands, it's very, very painful when you hit the most painful joint, for example. So it's absolutely enough to use it with the big one and really run over the whole hand. And the carpal tunnel, please, because the swelling is sometimes a problem of the carpal tunnel too. So please use it for all the joints and go over the whole hand over the carpal tunnel.
Okay, so carpal tunnel indication, you can use it also for trigger fingers, with arthrosis as well.
Yeah, trigger fingers is the problem. You get the pain away, but the triggering is sometimes you cannot change this. But the swelling goes away and the pain goes away, and for the patient, this is sometimes enough. Okay. But the carpal tunnel is great. For example, I know pregnant ladies are normally contraindications, but bad carpal tunnel with a pregnant woman you cannot give her the medicine to get it better, but they are suffering. It's really a problem. Sometimes they can't feel their fingers anymore. And if you use shockwave, you have to be as far away from the stomach, from the belly, of course, as possible. But if you use it like this, you can help them with 2 or 3 treatments very, very well, and you have absolutely no chance to reach the baby.
It's under responsibility, but there's no,
absolutely impossible.
No impact. Okay.
Because the shockwave goes in this direction and the baby's here. So.
And you can get an exceptional result for sure on the hands.
I had patients. Pregnant women which had the opportunity to get operated because the problem was so big. So an operation here during the pregnancy, I think then I use the shockwave 2 or 3 times much easier than to do an operation. But it is still a contraindication. You have to talk to her and explain it to her. And if she said, okay, I can understand, there's no chance to have any influence, then they will undersign it and it's okay. But you have to tell them that it's a contraindication, of course.
Okay. Thank you.
So
It can also have be used for spastic, to improve spastic
Yes,
movements in the hands. Yeah.
with absolutely great results. There are specialists, Antonio Moral, the chief of University of Barcelona. He has got a lady working with shockwave only with spasticity patients. Unbelievable results. It's absolutely great. We're working with 2 patients at the moment with this, from this to hello, in 8 weeks. So I think we can do a lot, and we can do a lot with spasticity to decrease the how do you call it? The Botox now. Because now they get Botox syringes, and this is something that I don't like. And with shockwave, I think in most of the cases you can get Botox away if you do it
on a regular basis.
Regularly, yeah.
Okay. Wow. Perfect. Thank you so much, Peter. I think we're coming to the end of our webinar. We have no other questions so far. In any case, if participants have other questions, additional questions, they can get back to us, and we will forward you the questions. Thank you again, Peter. That was an amazing practical session. Thank you, Claudia, for your participation as well. And wish you a quick recovery. And thank you all for joining this webinar. I hope you enjoyed the session. We'll see you. So for now, we'll see you all next year in January, and keep you posted about the next dates for 2022 New Year. Thank you again, Peter, and we keep in touch, and see you next time online. And please take care, all of you. Thank you again.
Wish you all healthy Christmas.
Thank you. Happy Christmas. Bye-bye.
Bye.